Today I am going to present my seminar about the Brugada syndrome, which is theoretically in literature it is a very common entity which present with sudden cardiac death in young patients. But many of these cases of Brugada syndrome goes misdiagnosed due to lack of knowledge or conflicting ECG findings with ischemic heart disease and associated conditions. Coming to Brugada syndrome, it is syndrome characterized by poor ST segment elevation with cleavage emerging right precaudal leads of ECG. It is first described by Brugada brothers in 1992. It is associated with right bundle branch block pattern, ST segment elevations, and sudden cardiac death. Significant advancement have been made over past 30 years in understanding the clinical entity of Brugada syndrome. Due to risk of sudden cardiac death, it is crucial for clinicians to accurately identify and manage the patients which suspected having Brugada syndrome.
So it was not first described by them, it was first described in 1989 by some other persons. There are typical pattern and sudden cardiac death was linked. It was named as Brugada syndrome in 92 by Brugada brothers.
Pattern is already
syndrome
with clinical.
So 89 में described हो चुका.
Prevalence type 1 ECG of Brugada syndrome is classical Brugada syndrome is approximately 1 in 10,000, which can be as high as 1 in 2,000 of individuals as per the literatures. Type 2 or type 3 ECG is approximately 1 in 5.
So type 1 ECG and type 2.
Now sir.
I said Brugada syndrome.
Yes sir.
अलग-अलग पैटर्न આવશે સર.
अच्छा Brugada એટલે ECG ની પેટર્ન.
Brugada માં ECG ની ત્રણ પેટર્ન છે.
Yes. Approximately 1 in 5. It is most common in Asia, followed by Europe and US. Prevalence in general population is difficult to estimate as ECG patterns can be dynamic and concealed, which can be normally routine, but intermittently there can be pattern of Brugada ECGs. Gender distribution: males are most commonly affected than females. Around 80 to 90% of the diagnosed cases males. The gender disparity becomes apparent after adolescence.
So જે તમે prevalence માં જે last sentence લખ્યું છે that true prevalence in general population is difficult to estimate.
Yes.
As ECG changes may be dynamic or concealed. So
Concealed.
how you can say that?
Because most of the generally patient when present with fever or anything, the precipitating factors, at that time ECG can be suggestive of Brugada syndrome. Otherwise, ECG can be normal. That's why true prevalence.
So it's like if a patient of Brugada syndrome comes in an arrhythmia, તો એમના past ECG જોવો તો એ normal હોય એટલે એવું કહેવામાં આવે કે આ concealed હોઈ શકે કે dynamic હોઈ શકે.
Yes.
Right? કારણ કે post VTVF તમારો ECG classical Brugada બતાવતો
Yes,
હોય, પણ જો fortunately પહેલાનો ECG હોય patient પાસે ને એમાં normal હોય that can તો આ વાક્ય કહી શકે.
Yes. Age dependency. Phenotype expression is age dependent. Although the original Brugada case series included the children's, but prevalence in children is very low. It's around 1 in 20,000. Typical age of onset is 30 to 40 years. That is mean age of sudden cardiac death is 41 plus or minus 15 years. Sudden cardiac death and cardiac arrest in Brugada syndrome. Brugada syndrome accounts for 20% of the cases of sudden cardiac death with apparently normal hearts. Responsible for approximately 5 to 10% of the cases of resuscitated cardiac arrest. Estimates are very based on age and ethnic background of cohort. Leading cause of death of men under 40 years of age in the region where inheritance is endemic. Percentage of clinically affected patient with at least one cardiac arrest before 60% is only 10 to 15, contrary to belief and literature.
So correct?
Yes sir. When they analyze cohort retrospectively, they observe this findings.
So તમારું death rate જે છે તો average rate તો 41 plus or minus 15 છે.
But total patients with Brugada syndrome when analyzed retrospectively, they have only 10 to 15% of the patients with sudden cardiac
એટલે આમાં આવા જ વાક્યો આવે છે.
They mention in literature. Coming to pathophysiology of Brugada syndrome, everyone knows it is a channelopathy. There is a voltage gated sodium channels which are transmembrane proteins essential for electrical signaling in neuromuscular This variant can lead to defective gating properties and reduced trafficking of sodium channels across the cell membrane. Dysfunctional sodium channel result in reduced sodium currents and shortened action potential durations. This sodium channel function is influenced by temperature, with gene variant affecting sodium channel leading to further shortening of action potential duration at higher temperatures. This SCN5A variants are most definitely cause of Brugada syndrome, but they are only found in 20% of the patients with Brugada syndrome. There are also other genes like SCN10A, including sodium channel 8 genes, and other genes encoding beta subunit of sodium channels are also involved in Brugada syndrome. The net effect of the genetic variation is reduction of inward sodium current and calcium current and increase in outward potassium currents. This
So
slide.
ક્યારે પણ gene describe કરો ને, you need to tell the genetic inheritance.
Yes, genetics have kept different slides. This slide summarizes the pathophysiology of Brugada syndrome. Here we can see this is a normal cardiac action potential. There is a very less gradient between epicardial and endocardial action potential. But during Brugada syndrome, there is a reduced sodium channels current. So there is increased the transmural dispersion of repolarization, and there is a transmural gradient which is responsible for typical coving appearance. So coming to the there is a summarizing the pathophysiology. There is a genetic cause, there is a polygenic risk accumulation which cause functional abnormality of sodium channels, cause repolarization abnormality, and there is also some structural abnormality not evidenced by echocardiography, which includes macroscopic finding like dilated right ventricular outflow tract motion, and microscopic findings like myocardial infarction, fibrosis, vascularization, lymphocytic infiltration, which cause repolarization abnormality. These are baseline abnormalities in Brugada syndrome, which can be triggered due to various factors, which we will discuss.
What is the cutoff for right ventricular outflow tract dilatation?
It is 2.8 to 3.
2.8?
Yes,
So that's huge.
right.
છે લખેલું છે કે
नहीं sir.
देखना ना बता.
Yes. So coming to the genetics of the Brugada syndrome, it is an autosomal dominant disease with incomplete penetrance. Penetrance is not fully. The first gene, which is SCN5A on chromosome 3, which encodes for alpha subunit of sodium channels, is responsible. More than 80 mutation of SCN5A genes has been linked to Brugada syndrome since 2001. Only less than 20% of clinically diagnosed Brugada syndrome accounted for this mutation. Genetic testing is recommended for Brugada 1 ECG pattern to allow familial screening. Presence of pathognomic variant alone is not diagnostic. Penetrance of identified variants in family is around 50%. Primary focus of SCN5A gene and other gene considered in special cases. Coming to clinical manifestations of Brugada syndrome, the most common clinically presented cases present with syncope, cardiac arrest, or sudden cardiac death from ventricular fibrillation or ventricular tachycardia. Other monomorphic ventricular tachycardia is there, but it usually found in SCN5A variant carriers. Typical age of first event is 30 to 50 years. Female may experience events in earlier or later in life. Pediatric life-threatening events as sudden cardiac death are rare. At diagnosis, 33% of the patient presented with syncope and around 66% of the patient are asymptomatic. There can be other arrhythmias also, like approximately 20% of the Brugada syndrome may develop SPT. AF is associated with 10 to 20% of the patient. Incidence of atrial arrhythmias is higher in the patient with ICD indication, which causes inappropriate shock in 40% of the patient with ICD. There are different modulating and precipitating factors in Brugada syndrome. There is a genetic defect, which is underlying defect, and there are precipitating factors summarized here like fever, ischemia, multiple drugs like sodium channel blockers, calcium channel blocker, beta blockers, and various electrolyte abnormalities, hypokalemia, hyperkalemia, hypothermia, or post-DC cardioversion. This cause more reduction in sodium channel and calcium channel and increase outward current of outward potassium channel, which causes four type of ECG pattern and short coupled TVCs followed by polymorphic VTs. These VTs are mostly self-terminated VT or VF, But due to underlying condition, this can be sustained VF and cause sudden cardiac death or cardiac arrest. Coming to the ECG patterns of Brugada syndrome, type 1 ECG pattern is the most diagnostic. That is chord ST segment elevation more than 2 mm with negative wave in right bicordal. This is classical of Brugada syndrome. Because these findings cannot present in every normal ECG, there is some modification done for ECG recording. That is placement of right bicordal leads in superior position, that is up to second intercostal space above the normal, can increase the sensitivity of ECG for detecting Brugada syndrome. I have placed the slide in this. The ECG changes can be sporadic, influenced by fever or medications. Other type 2 or type 3 pattern ECG are not diagnostic, but this is ST segment elevation more than one right bicordal leads under baseline condition with convergent to type 1 following challenge sodium channel blocker is considered a positive. One or more clinical factors should be present to say the patient has Brugada syndrome with type 2 or type 3 ECG patterns. Provocation testing with sodium channel blocker is important to label the patient with Brugada syndrome. But when provocation drug-induced ST segment elevation less than 2 mm is considered inconclusive, and drug-induced ECG conversion from type 3 to type 2 is also considered inconclusive. Coming to the ECG patterns, this is
How frequent are type 1, type 2 and
type 2, type 3 are more common, sir. Type 1 is less common, sir. I have mentioned prevalence according to literature. It is 1 in 500. They say type 2, type 3 ECG patterns. Coming to the specific ECG abnormalities in Brugada syndrome, this is a type 1 ECG in Brugada syndrome. It is a prominent chord ST segment elevation displaying J wave amplitude more than 2 mm. Here we can see J wave amplitude more than 2 mm, followed by negative Q wave inversion. This is a classical Brugada ECG type 1 pattern. Type 2 and type 3 pattern. Type 2 has more than 2 mm of J point elevation with the saddleback appearance. This is a saddleback appearance. It can have positive or biphasic T waves. And type 3 is somewhat like type 2, but the ST elevation in type 3 is more than 1 mm. You can see type 2 and type 3. There is ST. Only difference is about ST elevation to differentiate type 2 and type 3. This is a classical, but type 1, we have to remember this is a classical of Brugada syndrome.
Type 2 and 3 most of the time will be considered partial LTB or RDB or like that.
Yes, yes.
So it is pass it on as a
Yes, yes. Partial. This can also be considered as acute myocardial infarction of anterior leads. But I have mentioned earlier, we have to do sodium channel blocker provocative testing to define the classes to see does it convert in one or not.
તમે તમારા સ્ટાફને જ્યારે પૂછ્યું કે V2 ને V3 ક્યાં મૂકવાની હોય છે? કહાં पे आता है V2?
With the 14th intercostal space left parasternal area, sir. I have mentioned this slide is next.
So most of the time if you see the staff putting leads, they are making a big round circle from whatever place, right? Okay, so such a small sensitive things may be very easily distorted.
Electrophysiologist or when Somugora sir came, sir, they asked put ECG leads in front of my eyes.
Yes, exactly.
Because position is very important to diagnose this type of condition. Like ERVC also, sir. Changes in V1, V2, right side because you have to accurate.
Putting wrong lead placement is one of the cause of underestimation of this.
Yes, sir. That's why there is high lead placement also. I will describe this. It should be stressed that type 1 is the only ECG diagnosis of Brugada syndrome, while type 2 or type 3 should be considered the suggestive of disease, is not diagnostic. Here we can see this is a normal lead placement in normal patient. V1 is right parasternal, fourth intercostal space, and subsequent leads. But to diagnose, to reveal the concealed changes in Brugada syndrome, we have to move the leads in upward intercostal space. This is a modified Brugada lead placement of 6 leads. Then HV1, HV2 is right and left second intercostal space. HV3, HV4 is a third right and left intercostal space, and HV4, 5 is normal V1, V2 leads. This is a modified lead placement for Brugada syndrome. Here we can see the normal ECG with the normal ECG lead placement. But when we place the lead in high intercostal space, here you can see that the V1 and V2 shows the core ST segment with TBA inversion suggest of Brugada syndrome. This ECG diagnostic of Brugada syndrome.
This is just to increase the ECG sensitivity.
ECG sensitive and conceal the Brugada syndrome patterns. Because
हमारे population में incidence ज़्यादा हुआ है तो ऊपर higher level पर ले होना.
but many of the time patient present with syndrome and we have to see the clinical history also. The patient present with syncope, we are suspecting cardiac syncope, and we don't find any diagnosis. Then we can take the modified ECG.
પેલે history વાળા હોય ને એનો બીજો ECG normal હોય તો તમે એમાં જોઈ
Yes. That's why this is special Brugada pattern high parasynchronic ECG is important. Not in all patients, sir. In suspected syncope, sir. Coming to the sodium drug pharmacological.
Are there any idea by which we can diagnose Brugada syndrome? It is the only ECG.
Only ECG, sir.
ECG. So we have to do this.
Yes. And second is unmasking by drugs, sir. There is a sodium channel blockers test. Sir. There are 4 agent.
Brugada factor કેવું હતા? આવતું નથી એમ બ્લડમાં. Brugada factor એવું કે બ્લડમાં
Diagnostic
The
criteria.
echo is absolutely normal. I guess.
How
That-
frequent is Brugada? What is the frequency in the population? Sorry, I was late.
Frequency, as per literature, they see 1 in 10,000, sir.
That he has mentioned first line.
Other methods used to unmask Brugada syndrome are pharmacological like agemalin, flecainide, procainamide, dicylflecainide. This can use to unmask the Brugada pattern. That is, this is a baseline ECG of patient present with syncope, and when we give procainamide infusion, at the end of infusion, we can see here Brugada pattern ECG in V1.
So you will give this challenge to all cardiac syncope survivor or just for those who are having type 2 or type 3 ECGs?
Type 2, type 3 ECGs, sir. Yeah, a baseline normal ECGs with suspected cardiac syndrome to unmask the Brugada patterns. Not every patient.
But type 2 type 3 હોય તો જ.
Yes, sir. Type 2, type 3 को type 1 conversion हुआ है कि नहीं?
type 2 type 3 ना હોય तो नहीं आपको
तो भी देता है सर.
देता है ना?
ये तो नॉर्मल है सर.
ना इसको आप सेटल V2 में बोल सकते हो थोड़ा बहुत. Why not? This is type 3 here.
You can आप यहाँ पे बोल रहे हैं सर?
हाँ उसका T से पहले का नीचे जा रहा है देखो वो type 3 पैटर्न है. Zoom in.
Third lead में थोड़ा दिक्कत है.
ना थर्ड लीग में तो नहीं है बट लीग
And
टू
we have
सेटल
to
बैक
elevation चाहिए.
It's a more than
सेटल बैक और एसटी एलिवेशन दोनों है बेटा.
हाँ, more than 2 millimeters and J point elevation more than 2 millimeters.
वो तो आपका इसमें हुआ ना टाइप 3 वाला पैटर्न है ये जो V2 में दिख रहा है ना वो इट इज नॉट नॉर्मल.
But sir, sodium channel provocation testing is advised in normal individual also, and to see the type 2, type 3 ECG is converted in type 2
मतलब नॉर्मल में कर सकते हैं ना दैट इज
Yes.
व्हाट माय क्वेश्चन.
Yes,
ओके
yes.
आई गॉट माय आंसर.
Coming to differential diagnosis of Brugada syndrome, there are very much clinical entities listed here that for stimulation in V1 and V2. Most common in our clinical setup is acute myocardial infarction. I will be discussing some cases of this because Brugada syndrome, in our clinical practice, most commonly confused with acute myocardial infarction, that is antrovolemi, so that this patient also have ST elevation in V1 and V2. Sir. Other different conditions like a typical bundle branch block, myocarditis, pulmonary embolism, and different electrolyte abnormalities and drug-induced changes can also be there. So family screening, which patient of Brugada syndrome should undergo family screening? All first degree relative of diagnosed patient or unexplained sudden cardiac death cases should be screened. This includes high lateral lead ECGs, sodium channel blocker provocation test if necessary. Here it is indicated for family screening, sir. In children, initial screening at the age of 3 and then every 3 years until age of 15. Routine sodium channel blocker provocation test in children is not recommended until age 15, sir. Other tests includes baseline echocardiogram to exclude other structural heart disease, sir. Additional cardiac imaging like MRI in complex cases to assess RVOK and structure and functions. So, how to diagnose the Brugada syndrome? In earlier times, sir, pre-2016, only type 1 ECG changes, either they are spontaneous or induced, are considered diagnostic. After that, there is a Shanghai score developed, which tells the criteria for diagnosis of Brugada syndrome. It includes various parameters. First is ECG findings, clinical history, family history, and genetic testing. Each factors given specific points, and the point system more than 3.5 or more is the definitive diagnostic of Brugada syndrome. 2 to 3 is possible, and less than 2 point is non-diagnostic of Brugada syndrome. This findings include spontaneous type 1 ECG, which is a classical given 3.5 points. The fever induced type 1 ECG 3 points, and type 2, type 3 ECG that converts to type 1 ECG sodium channel blocker provocation gives 2 points. Other points include clinical history like sudden cardiac death, undocumented VTVF, nocturnal agonal respiration, suspected arrhythmic syncope of unclear etiology, AFL before 30 years of age. Family history mentioned here, and genetic testing is not suggested of Brugada, it is given only 0.5 points.
So much.
Yes, and already mentioned earlier, so only 20% of the patients with Brugada syndrome have specific genetic mutations.
What is probable pathogenic mutation? Mutation તમે ચેક કરો તો કન્ફર્મ ના આવે.
Sorry, sir.
Genetic testing માં the comment is probable pathogenic mutation.
There are more than 80 mutations, sir. Probable like 2-3 mutation they advise SCN5.
But in genetic analysis, will you get the answer like probably there is a mutation? એવું આવે ક્યારે? તો definitive હોય કે ના હોય?
Yes, sir. Mutation to definitive
What is the meaning of probable pathology? It is a genetic testing કર્યા પછીનું
Yes,
છે.
sir. मतलब सर ब्रुगाडा सिंड्रोम में जो 7-8 जीन रहते हैं, उस जीन जो उसका म्यूटेशन आया तो ब्रुगाडा सिंड्रोम. प्रोबेबल जीन्स कॉजिंग ब्रुगाडा सिंड्रोम ऐसा लिखा है सर. टेस्ट का प्रोबेबल नहीं, वो तो टेस्ट पॉजिटिव ही आएगा.
નથી સમજાતું.
Very scientific.
એટલે એવા બી કોઈ જીન છે કે જે કરે છે કે નથી?
For example, sir, sodium channel 5 mutation also can be seen in long QT syndrome also, sir, because overlapping can be there.
Well, we may not be sure that this gene is responsible. That's why it is only 0.5. And the genes only
There are many channelopathy, SQTS, LQTS also have sodium channel mutation.
So you want to say કે જે definite gene છે એ gene સિવાયનું બીજું કાંઈ mutation આવે તો probable માં આવે.
हाँ, yes, exactly.
Okay. ચલો જોઈએ.
As per standard.
ચાઇનાનો માલ છે ને?
Right.
But as per society is recommended to diagnose the Brugada.
So currently this is the diagnostic even
Yes.
today also.
But लिटरेचर में नहीं, इसमें नहीं है सर, गाइडलाइंस में नहीं है, पर लिटरेचर में बोला है कि
हाँ तो एसएससी ये एएससी ये सब कहाँ पे है सारे एचए वगैरह इन लोगों का कुछ नहीं है.
आगे है सर, उसमें
आगे है?
ये है सर.
तो वो दिखाओ.
ट्रीटमेंट गाइडलाइंस है इन हार्ट रिदम सोसाइटी की, वो तो थोड़ा ओल्ड गाइडलाइंस है 2013.
हाँ तो वो
उसके बाद कुछ अपडेट्स नहीं है, तो अभी का अपडेट ये है सर.
क्या बात कर रहे हो यार. ठीक है चलो.
Coming to risk stratification and consideration, the main aim of Brugada syndrome patient is to stratify the risk of the patient whom you should evaluate most, which includes a patient with serious cardiac arrhythmic events, which includes the sudden cardiac death or resuscitated cardiac arrest. To identify this patient, various risk stratification involves clinical ECG and electrophysiological factors. Clinical factors in this patient includes cardiac syncope. Patient with history of cardiogenic syncopes to have 2.5 to 5 times of more high risk of sudden cardiac serious adverse cardiac events. Syncope combined with spontaneous type 1 ECG increase the annual incidence of SAE to 2.3 to 3.6%. Spontaneous type 1 ECG, this pattern alone can raise the risk of serious adverse event by 2 to 6 times. Age and sex, with older age and the diagnosis might suggest the low risk. Overall patient age and sex does not significantly affect events when other factors are considered. Family history with early sudden cardiac death, that is fertility less than 35 years, may increase the serious adverse event risk. Summarizing the main factors to be considered is cardiac syncope and spontaneous type 1 ECG as per the clinical factors. ECG patterns, Brugada pattern already discussed. Other ECG abnormalities like fragmented QRS, prolonged QR duration, early revolution pattern, TPK and duration, QTC intervals can provide additional diagnostic information and used to stratify the risk of Brugada syndrome patients. Programmed ventricular stimulation during electrophysiological studies. It has a controversial role, but it shows mixed result in predicting serious adverse event. Some studies support use while others doesn't. But selective use of PVS can be used as a tiebreaker in specific cases where a patient is spontaneous ECG changes and syncope of uncertain origin. We can use the programmed ventricular stimulation.
મિત્ર તમારું ક્લાસિકલ ECG ચેન્જીસ હોય અને સિન્કોપ ઓફ અનનોન ઓરિજિન હોય બરાબર તો એ ડેફિનેટિવ ડાયગ્નોસિસ સાંઘાઈ સ્કોર પ્રમાણે તો થઈ ગયું 4 થઈ ગયા રાઈટ
ओके
તો क्या करने की जरूरत है
वो तो सर टाइप 2 और टाइप 3 ये तो करना पड़ेगा सर टाइप 1 में तो करना ही नहीं सर टाइप 1 का ECG मिला सिंको पे तो डेफिनेटिव डायग्नोसिस
One is classical diagnosis.
तो उसमें लिखिए आप कि टाइप 2 टाइप 3 ECG
Coming to management strategies, sir. There are three management: conservative, pharmacological therapy, and intervention therapies. Conservative measures include avoid the drug that can provoke the Brugada ECG patterns. Rapid antipyretic treatment for fever, particularly important for pediatric patients, and avoid excessive alcohol intake and manage acute metabolic disturbances properly. Pharmacological therapy, pyridine is the main drug recommended for Brugada syndrome currently. Useful for managing Brugada syndrome due to anti-arrhythmic properties. Low-dose pyridine may improve its tolerance. Isoproterenol also recommended in Brugada syndrome in electrical terms. Other agents include phosphodiesterase 3 inhibitors can also be considered. Here is the current recommendation for pharmacological therapy for Brugada syndrome. Is the main drug pyridine can be pyridine is the main drug which is indicated in stroke, VF prophylaxis or asymptomatic Brugada syndrome. At present, asymptomatic Brugada syndrome only pyridine is considered. Other drugs like risperidone, isoproterenol, and other can be also used as a pharmacological therapy.
VF prophylaxis is primary or secondary?
VF prophylaxis is secondary prophylaxis.
Secondary.
Yes. And BT stop is secondary.
These drugs to be given, suppose on routine ECG you found type 1,
Yes.
then you have to give or type 1 plus syncopal attack you have to.
सर मैनेजमेंट स्लाइड डिस्कस करेंगे सर उस पे तो पूरा डिटेल बताएंगे तो
When other drugs are used, except pyridine, when pyridine not.
this here it is star marks like denopamine can be used in VF prophylaxis, silostazol can be used in VF prophylaxis, betadine can be used in VF prophylaxis.
So what is drug of choice for VT stop?
It is pyridine only sir.
It is
But
isoproterenol.
isoproterenol can be used. Only BT stop 2 drugs are mainly used. Isoproterenol
Drug
and
of choice
pyridine.
is isoproterenol.
Yes. Device therapy is indicated in secondary prevention of patient with history of resuscitated cardiac arrest. Primary prevention of ICD for those with history of we will see device therapy in subsequent slides. Coming to some cases of Brugada syndrome, 3 cases I will summarize. First case is 61 years old male doctor, history of hypertension, hyperlipidemia, good exercise tolerance with frequent jogging, attended ER for epigastric pain for 1 day, fever since 1 day, no angina, palpitation or any cardiac symptoms. Sir. This is the ECG of this patient sir, on admission. Sir. Here you can see lead V1 and V2, there is ST elevation, J point elevation with T-wave inverted. Coming to investigations, investigations showed deranged liver biochemistry. Cardiac evaluation shows
67 bilirubin છે કે 6.7 પ્રભુ મારી નાખશો તમે
cardiac evaluation in this patient, echocardiogram showed no segmental wall abnormalities, no. For benefit of doubt, this patient was transferred to cath lab for coronary angiogram to rule out acute coronary syndrome. Coronary angiogram revealed only minor insignificant coronary artery disease. But during coronary angiography, this is the ECG pattern we observe. This is a normal ECG pattern followed by polymorphic ventricular tachycardia, which is resuscitated by intervention. So he has a history of medicine only amlodipine and atorvastatin. The diagnosis was primary diagnosis was sepsis, which eventually turned out to be biliary origin, UHG abdominal, rest of treatment as per gastrologist. This is the second ECG after discharge of the patient. There is absolutely no. This is a type 2 pattern, Brugada pattern in V2. So in this patient, Brugada ECG pattern type 4 is spontaneous. There is about a sudden cardiac death, documented VTVF during febrile illness, no previous history of recurrent syncope, and no family history of Brugada syndrome, Brugada pattern of sudden cardiac death.
તમે VTVF કઈ રીતે કંટ્રોલ કર્યું?
In literature, this is taken from literature. They say it's by cardiac shock.
तो आपका केस है ना ये आपका?
नहीं,
आपका केस है?
केस सीरीज है
अच्छा,
सर, Brugada syndrome में से केसेस है।
कार्डियोवर्ट किया?
हाँ सर,
अच्छा,
detail not available.
okay.
So in this patient, EICD implantation was secondary prevention of sudden cardiac death, avoid proactive drug, prompt treatment of febrile episode, surgery for gallbladder to avoid recurrent diseases. So this is a Brugada syndrome patient, symptomatic patient about a sudden cardiac death. There is ICD should be inserted in this patient. There is a second patient. He is a 73 years old retired government servant. History of syncope since 2010. Baseline ECG and portal modelings are unremarkable. This is a baseline ECG of this patient. This classically you can see Brugada pattern V1 V2. Cardiologist were called upon stimulation MI, but they echocardiogram revealed the normal LVF with no segmental wall abnormalities. Type ECG was promptly recognized as type 1 Brugada pattern. There was no further episode of syncopal attack or no ventricular supraventricular tachycardia has been documented. He did not use any history of angina all along. He did give history of 3 to 4 syncope episodes in past. But this is syncope with Brugada 1 type 1 ECG, which is spontaneous type 1 ECG. He is a definite diagnostic of Brugada.
તો એકવાર વોલ્ટર થયો તો પણ કદી બ્રુગાડા પેટર્ન નહોતી આવી એવું?
નહીં. And he has a history of fever. This fever induced ECG, sir.
तो तब सांघाई गाइडलाइन नहीं होगी, किसी ने प्रोवोक नहीं किया होगी?
नहीं सर. तो syncope neurally meditation होते हैं. After fever subsided, this is absolutely normal ECG, sir. So where this case stand for? These are type 1 Brugada ECG during febrile illness. History of recurrent syncope, query mechanism, no documentation of VTVF. Co-committed coronary disease is there, but not significant. The discussion was held with patient Brugada syndrome with recurrent syncope. Coronary angiography shows incidental finding of mid-LED stenosis, not accountable for presentation of ECG findings. And plan of ICD implantation followed by PCR afterwards was taken in this patient.
73 years of age,
According to protocol.
વેસ્ટર્ન વર્લ્ડ છે ને આપણો થોડો.
So
હવે પ્રભુ તમે નીચે બધે આઈસીડી લઈ જવાના છો તો આજ બોલી દો. કે ચેન્જ આવતો હોય તો અલગ વસ્તુ છે. કે આઈસીડી નાખવાની હોય તો શું કામ મગજમારી કરે?
final charge.
How much time after fever subsides the pattern disappears? During fever the pattern occurs or
With presentation when patient has active fever, at that time patient has ECG of Brugada pattern. After discharge they say ECG.
So fever જ્યારે સબસાઇડ થાય કોઈ પણ ઇન્ફેક્શન નો, that doesn't mean કે ઇન્ફેક્શન સબસાઇડ થયું છે. આખું મેટાબોલિક ચેન્જીસ we might take few days to few hours. So એક દરેક ફીવર ના સ્પાઇક પછી પેટર્ન સબસાઇડ કદાચ નહીં થતી હોય.
એટલે ફીવર સિમ્પટમ વાળા બધા પેશન્ટોને આપણે ECG
ના ના ફીવર
Young,
ફીવર ના
સર
પેશન્ટ
સિન્કપીમાં નોકલ કરવાનો
એટલે તમે 2 ને 3 પણ ડિટેક્ટ થઈ ગયું.
Syncope is there.
Syncope તો કરવી જ પડે છે.
Cardiac or neural syncope. Vagal mediated syncope.
તમારું કેટલું બાકી છે जी?
तो ऐसे लास्ट का साइड है.
अच्छा, आप इसलिए भाग रहे थे इतनी जल्दी से, वो सब डिस्कस करने लायक था यार, काफी भागे आप.
टाइम हो गया इसी
तो
और एक केस
अगले वेडनेसडे कर देते हैं ना, कोई बात नहीं, अपने पास टाइम ही टाइम.
This is a last recommended according to Heart Rhythm Society, sir. There is class 1, class 2, class 3, class indication. In class 1 indication, main they recommended lifestyle modification already we have discussed. Second, ICD implantation is recommended in the patient with Brugada.
क्या लाइफस्टाइल चेंजेस तो मैं रेकमेंड कर
So avoidance of drug that may induce STD, elevation, excessive alcohol.
ECG recommended by whom?
अला ड्रग से लाइफस्टाइल चेंजेस करा.
Excessive alcohol, lifestyle and other modifications, sir. lifestyle includes
Avoid
excessive
alcohol.
alcohol intake, avoidance of alcohol intake, immediate treatment of fever and antibiotics. That's only they mentioned. ICD implantation is recommended in a patient with diagnosis of Brugada syndrome who are survivors of cardiac arrest and who have documented evidence of spontaneous sustained VT or VF with or without syncope. This is ICD class 2 indication.
नॉन सस्टेन હોય તો સસ્ટેન થાની રાહ જોવાની ને એક એપિસોડ માં
This is class 2A
ઓ
indication.
ક્લાસ 2 है
But डालना तो है sir.
ओके
ICD indication can be useful in patients with spontaneous ECG type 1 who have history of syncope judged to be likely caused by ventricular arrhythmias. In class 2 indication, pyridine can be useful in the patient of Brugada syndrome with history of arrhythmic storms defined as more than 2 episodes of VT/VF in 24 hours. And class 2B indication of ICD implantation may be considered in the patient with Brugada syndrome who develop VF during programmed electrical stimulation, that is inducible patients.
So that's when it is for further prophylaxis or for treatment.
Sorry sir?
That class 2A માં તમે જે fourth number નો point બોલ્યા quinidine can be useful in patient with diagnosis of Brugada, history of arrhythmic storm. So during storm it is indicated or for secondary prophylaxis it is indicated?
During storm indicated.
During storm?
Yes sir.
लागतू નથી.
यहाँ पे उन्होंने मेंशन भी किया है कि ड्यूरिंग स्टॉर्म 2 ही देना है, कैसोप्रेटिन और यहाँ पे मेंशन किया है और क्विनिडीन से. So coming to the interventional aspects. Prior cardiac arrest or sustained VT ICD recommended. Spontaneous type 2 ECG, history of syncope ICD can be useful. Inducible VF on EP study ICD may be considered as asymptomatic with drug-induced type 1 ECG or induced type 1 ECG, asymptomatic patient. Although it is a Brugada syndrome, ICD is not indicated, sir. Okay. So, coming to the final conclusion, we have to assess the patient with history, ECG changes and provocation test and do the diagnosis of Brugada syndrome. After that, we have to stratify the risk of the patient, establish markers with cardiac arrest, spontaneous type 1 ECG and cardiogenic syncope, and other markers to be considered like age, weight, and treatment according to conservative pharmacological intervention as discussed.